So this is my last talk, and it's about cell-derived therapies. And I already mentioned that I'm a believer in cell-derived therapies because I think that what we have for macular degeneration with anti-VEGF treatment is just that we might halt or delay the disease progress, but we are actually doing nothing to cure the disease. And so I think cell-derived therapies are mild therapies, and in ophthalmology we would have to look out to other fields which are already using stem cells and cell-derived therapies a lot to learn a little bit for ourselves. Ophthalmology is an area where we in general think we know everything in our small world of the eye, and we don't need the knowledge of other areas in medicine, but we do. So the background, I became very interested in transplantation of retinal pigment epithelium cells because it was shown in animal experiments that actually retinal pigment epithelium transplant might be able to preserve or restore vision in diseases with dysfunctional RPE, and that was shown in blind mice in the 80s and 90s. So these animals, they could not move, and when they had the transplanted cells, they actually could learn to move better. So in animals, it works. This tells you already the first thing. What works in animals does not always work in the human eye, but you need it. So human retinal transplantation followed many experimental research, showed that actually transplanted pigment epithelium cells have the potential to rescue photoreceptors. In AMD, the molecular mechanisms for neovascular AMD are not fully defined, and there are several pathways, but in general, there is oxidative stress culminating in RPE dysfunction and death. And unlike neovascular AMD, where blocking a single culprit molecule, the VEGF, can stop progression, redundant pathways for non-neovascular AMD, dry AMD, make the targeting of a single agent unrealistic. What are the main functions of RPE? You probably know. It's responsible for the regeneration of the visual pigments. It transports oxygen and nutrients to photoreceptors. It phagocytizes the photoreceptor outer segments. It maintains the subretinal microenvironment through production of cytokines and chemokines, and it forms the outer blood retinal barrier. Our RPE is incapable of self-removal, so the cells are as old as we are. RPE is considered an initial site for events leading to macular degeneration. And from the surgical approach, it's easily accessible as visible pigmented monolayer. You can see it and reach it, which also makes a lot of sense. Replacement therapy started in the 90s, and the proof of principle was actually retinal translocation. The surgery I told you before, that the retina was detached and translocated to an extrafoveal area, and with this surgery we did see that actually extrafoveal retina can learn to function as macular retina. And fetal and adult RPE was tested, but the cells that generated easily upon implantation, and these were the early years from P. Balquere, he is Swedish. He actually started this cell transplant, but in a much rougher way. The source is limited of these fetal and adult RPE, and there is the question of immunogenicity. These cases, the human cases he did first, they failed, and it was considered an immunogenic reaction. So, what is the principle? Here you have a neovascular AMD, where you would do actually excision of the neovascular membrane, but this always goes along with a loss of pigment epithelium. Why? No, the membrane is covered either, if it's subpigment epithelium, it's covered by pigment epithelium, or if it's on the pigment epithelium, so we had this type 2 and type 1 membranes, then you take away a lot of pigment epithelium in the area where the membrane is, and then you might end up with an atrophy. When I talked about subretinal surgery from Matt Thomas, he did removal of membranes in histoplasmosis cases. And these were young patients, and this worked quite well, because in the younger patient, you had more activity. In the old patient, if you remove a membrane, you end up with an atrophic area. The good thing might be that this case will not get exudative ever. The bad is that they cannot really read. Or you have pigment epithelium atrophy. So, in cell-based treatment, you can, this is the macular translocation. If you have atrophy, then you can do that either with a patch transplantation or a suspension. And I'll talk about this in the next few minutes. And the patches can be prepared as full RPE choroidal patches, or you ablate the choroid and have only an RPE patch. So it was clear for me, if there was an immunogenic reaction in the first cases, we need to go autologous. So I was looking for some autologous material, and it's in the same eye, of course. And I did create some suspensions with RPE. And what we did at that time was that, that we could have, in these cases, I show you some examples immediately, we could have significant result in subclinical tests, MRG, microperimetry, but not significant visual improvement with this technique. And so I did probably 120 cases at that time. It was the time when we did not have PDT, so we had actually access to these cases to do surgery. PDT did hinder the further development, because then PDT became the first-line treatment for 50% classic neovascularizations, which were the easy cases. We could not have surgery in that. But this is the technique, and I want to show this with you because it will always stay very similar. So how do I? Yeah. So what I did, in order to get autologous material, I created a bleb detachment nasally from the optic nerve, and I harvested pigment epithelium cells. I used a calcium-magnesium-free solution to loosen up the pigment epithelium cells, and I aspirated them. Then these cells were centrifuged and counted, and then I removed the membrane. And I said it's not so difficult to remove a subretinal membrane. You make a small incision and gently you remove it. And then I injected these cell suspensions, over the fovea under perfluorocarbon so that I did not have an efflux. And I did not close the hole with laser. They closed up on its own, and actually it was an easy, not by complications loaded surgery. And that's why I like the suspension, because it will always be the easier access. You just inject subretinally with a...
Did you ever get oral hemorrhages when you were harvesting the RTD?
No, in the nasal side, there was not very much. And the nasal side, the patient doesn't use the retina, and it also that you have full control in this area. You know, if you go more to the periphery, then you don't have this control. So, what I did find at that time was that I had much better outcomes in small membranes and younger patients. She was 55 years, and she actually regained full vision. And we have now a follow-up. This was, I think, 2002, so of 10 years. Here you see the area where I did harvest the cells, and here you see the fovea. This was the retinotomy. However, in old patients, it did not really work, because here you see a 78-year-old male, and you see that these pigmented cells, they end in the outside of the defect and did not improve any vision. And here you also see there might be a little bit more cell activity, but no visual improvement. Now, we did rethink our concept and thought, well, if we take it autologous, these are aged cells too. They have the same age. We place these cells in a so-called hostile environment. So Bruch's membrane is also defect, and also the choreo capillaris is not working so well. And we are limited with our cell harvest, because you can only harvest a certain number of cells. We calculated the area, how large it should be, but you lose a lot of cells while you transplant them with the syringe and a tubing. So then there were some of us which said perhaps we should transplant a full patch, cord, Bruch's membrane, and pigment epithelium, because then it would have a better support. And and the patches I did later, and at that time PDT was already here, and so I could only take the worst possible cases for this kind of surgery. These were usually patients who were already blind in one eye and had a large hemorrhage, as you can see here, after PDT. And then this is the patch 1 month after surgery. And this is the area where I excised the patch. The other eye in this patient had terminal AMD. This eye, when he came in, had hand movements. Postoperative, after 12 and 24 months, the vision, first it was 0.05, and then it went down to 0.02 because this patch did shrink over time. Okay. Still better than hand movements, but not really good. This is another case. The other eye, it's a nice lady, the other eye was enucleated already due to trauma, so she came in with the last eye, severe hemorrhage after PDT, hand movements. And here you see that the patch I used is larger, and it's in connect with the healthy pigment epithelium. And these cases, they survived much better because somehow they were bridging. And she gained 0.1 vision, and she could also read somehow with magnifying glasses on this only eye. So this is a bad case and a good case. In general, patch surgery is a very traumatic surgery which is loaded with complications. It's not an easy thing to do. And therefore, we did not have a significant successful gain on vision, and I have also stopped this kind of surgery after a while. Then anti-VEGF treatment came up, and everybody treated endlessly with anti-VEGF, and even big hemorrhages are now treated with anti-VEGF or TPA, but not with patch surgery. So what I've learned, and we all have learned, that we need more abundant, robust cells to create a feasible treatment option for cell-derived therapies in AMD. We cannot deal with this little aspiration of cells. And these are stem cells, of course, and the plasticity of the stem cells can optimize the ability to attach on aged or diseased postmembrane. This we know. And the two cell types which are used today are one, the embryonic stem cells, and what we learned is that if you have a pluripotent stem cell, you have to transfer them first into a pigment epithelium cells in the laboratory, and then you can use them for transplant. It's not that you inject them in the eye and they learn to behave like a pigment epithelium. You have to transfer them, and then there is large-scale expansion possible. They are pathogen-free, well-characterized, well-manufactured. Actually, there are a lot of companies which see big, profitable cell labs already growing. And they have a high degree of, similarity to in situ RPE by genetic testing. There is no embryo destruction, these are cell lines, but with the embryonic stem cells, immunosuppression might be needed again. And yes, you have.
Are there fully grown adult RPE cells then that are grown in the lab and then transferred?
Yes.
Or are still like young cells?
Well, they are fully developed RPE, yes. So the problem with immune suppression is still there. There are techniques which can make the cells themselves less immunogenic, but then they might lose some of their functions, so it's not solved really. It's also with immunogenicity that these cell-derived therapies in AMD, they are actually designed for elderly patients, and you don't want to put an old patient on the immunogenic treatment for a long time. So this is some unclear, yes?
I'm sorry, I have just one more. Is immunosuppression needed if we take like our cells, like stem cells?
No, if you take your cells, it's perfect.
Okay, yeah, okay.
So this is induced pluripotent cells They can also be differentiated, actually, and there are 2 Nobel Prizes that have been given to a Japanese and an American, I think, for the development of the hips. So they are taken from the skin, but they can also be taken from blood or umbilical cord. And they, of course, have not the risk of immune reaction. They do everything we want. The problem only is that they are also old. If you take it from an old patient, the skin, and there might be genetic abnormalities, but this is not really the main problem. The main problem with the hips is the high costs. Because if you create the cells from your skin to transplant them, it would cost several millions. And Japan was actually very active in this kind of research because they felt that the cell-derived therapies might replace anti-VEGF, which is a big load for every health system in every country. But with the hips, it will also be quite a big load. And now what they do, they use the hip cells, but they divide it in many little samples to make it for many patients, and then the immunogenic reaction will start again. Still, many technical and regulatory breakthroughs have made stem cells therapies for AMD more plausible, and there are actually clinical trials now using stem cell-derived RPE in retinal degenerative disease showing short-term safety. At the beginning of these trials, it was only about safety, so that the cells can be transplanted safely, that they did not grow into tumors. That was the question. Yes, will these stem cells actually, then look like a big melanoma sooner or later? They don't. The RPE cell is a very lazy cell. To make the RPE grow or do something, you have to do a lot. It just sits there. So, yes. But this was the issue, of course. And here you have one of the first studies by Stephen Schwartz, and it's published in the New England Journal in 2015. He used a series of 18 cases of either Stargardt or dry AMD, and here you see where he used a suspension. Stephen Schwartz is a lazy man. He likes to make things simple. And I tell you, the suspension is, of course, a very simple thing, and very soon we already do gene therapy with a suspension in children. So, and here you see some results, how these cells did grow, and another case here, and a third case here. And in this first series, they just did show that these cells are active. There was not really visual gain. That was not the goal. Then this is from Takahashi from Kobe City in Japan, and she is using, the hip cells and the flap. So they put the cells on a basal lamina, and they transplant a flap, subretinal. And they are showing some growth. I can tell you, the flap is very difficult to do technically. We have thought about 100 different solutions. If we can freeze them, fold them, inject them like a cell, like a lens, subretinal, so that it will unfold. those who are in favor of the flap, they would say, yes, then we also provide the basal lamina for these cells, and then they have a better ability to survive and to grow. But it's technically much more challenging. These flaps can roll and not adhere. The suspension has the disadvantage that you suspend a huge amount of cells. Now with the stem cells we can have huge amounts, but they will be rolled over or three lines, and they have to reorganize themselves. So this is Marco Mayon's work, and he's using an ultra-thin monolayer, as you can see here, and they did some multifocal visual fields, and it shows that these patients, they learn to focus. And this is from 2018. They have a larger number, and so there are now different studies also in Moorfields Eye Hospital in England. In Boston, they use, I think, blood-derived stem cells. In Los Angeles and in Japan. And fortunately, this group is growing. The disadvantage with this kind of research is that you can only use very bad late cases right now, because otherwise it will not go through an ethics committee, and therefore the vision gain is not big. There is also a group in Israel which is using also the embryonic stem cells as a suspension in advanced atrophic AMD. So many people are working on that. The remaining obstacles are: we need to develop a commercially viable source of RPE and retinal progenitors that are low cost, reliable, and robust. And we need to optimize the methods of delivery in the space. So there's this constant discussion about sheet or suspension. We need to prove that there is long-time survival and function of the implanted cells, because the genetic predisposition for the disease is there. Will they become atrophic again? If you know about the rotation studies, they showed that actually the patients after a while developed an atrophy in the extrafoveal area. So how long will it last? Is it safe? Tumor formation after years? Yeah, we are not considering that as a big issue. We need methods to leverage the immunoregulatory potential of the stem cell derived PE to minimize the risk of immune reaction. So that's what's still here, but we have learned also a lot in the meantime. So to summarize, there are now increasing solutions for better cell sources. There are adhesion and basal laminar reconstruction. There is pharmacological and technical improvement. I personally believe that we have to intervene much earlier in these cases, and once we showed it safe and easy, then we can go actually much earlier in the progress of the disease. And we need probably a method to stimulate the transplanted cells in some way. We need to talk with the molecular biologists what we might do to enhance, their potential. So progress for successful human retinal transplantation is constant, but it comes only in small steps. And this is my last word, because it's almost unbearable to go through that if so little happens over time. I always felt that cell-derived therapies, they need more than the life of one ophthalmologist when he is active. And that's the reason also that the younger doctors, they don't start where you have ended, but they start more or less in the middle again. And a lot of experiments are repeated for many different reasons, to do more research, to have their own results, and therefore we lose, the progress. But it's there, and I'm convinced sooner or later we'll have it. I was just in Bascom Palmer last week, where Adina Barakal is doing genetic stem cell transplants in blind children, and it will come from different sources. As I already said, I have read already that this topic is not interesting for many of you because you cannot use it right now in your daily praxis. This is acceptable, but I think to have the knowledge about what is happening might be also interesting for your daily routine, because you can inform the patients. And you will have these questions probably all the time. The right answer is not, oh, there is nothing happening. But the right answer is also, okay, it will be there next year. So it will probably take 3 to 5 years until we'll have a broader group which we can treat. This is reasonable. And so I think it's worthwhile to go into this area and look a little bit closer. And with this, I close also my lectures.